Hi everybody, welcome to our module on Sjogren syndrome. Sjogren syndrome is an autoimmune disorder that leads to destruction of the salivary and lacrimal glands, and as we will see, this leads to problems in the mouth and problems with the eyes. In the eyes, the symptoms of Sjogren syndrome are dry eyes. This is the natural consequence of autoimmune destruction of the lacrimal glands. The formal name for this is keratoconjunctivitis sicca, and the word sicca comes from a Latin word that means dryness. So this simply means dryness of the surface layer of the eye. And sometimes patients don't notice dry eyes, but instead what they notice is a feeling of dirt or debris in their eyes. And this is what occurs when you don't have normal tear production from the lacrimal glands. In the mouth, the symptoms of Sjogren syndrome are dry mouth, which is also called xerostomia. Sometimes the way patients notice this is when they try to chew dry foods. Crackers are a classic food. You need lots of saliva to chew crackers, so if you develop Sjogren syndrome, one of the first things you may notice is that it's very hard to chew foods like crackers. Sjogren's patients can also develop cavities from the loss of saliva, and they can also get bad breath. In addition to symptoms in the eyes and mouth, which are the hallmark of Sjogren syndrome, there are a number of so-called extraglandular disease symptoms that occur in other tissues. One of the most common is for symptoms to develop in the skin, and the most common symptom is xerosis. This is dry, scaly skin. It often occurs on the lower extremities and especially in the axilla and the armpit. Other problems that people with Sjogren's can develop include joint symptoms. They can have pain in the joints, which are called arthralgias, or they can have inflammation of the joints, which is arthritis. In addition, they often develop Raynaud's phenomena. This is ischemia of the hand that gets worse in cold weather due to over-vasoconstriction of the blood vessels. This can occur in a number of conditions. It's often part of scleroderma. You can also see it in lupus, but it also happens in Sjogren's. And then in addition to these symptoms I've listed on the screen, there are many other potential symptoms. You can read about involvement of the heart and lung, but these ones on the screen are the most common areas to be involved. Like many other autoimmune diseases, Sjogren syndrome is more common among women. The typical age of onset is usually in the 40s. And just a side note here, on your clinical rotations, you will meet many elderly patients who have what's called sicca symptoms. These patients have dry mouth and dry eyes. This is related to aging. This is not due to Sjogren's. And if you do some of the antibody tests we'll talk about later, or if you do a biopsy of the salivary gland, this will be normal because their sicca symptoms are not coming from an autoimmune disease process. Sjogren syndrome is a lymphocyte-mediated autoimmune disorder. It's considered an example of a type 4 hypersensitivity disorder. And this is actually important clinically because when you biopsy the salivary gland, what you will see are lymphocytes. The characteristic finding of Sjogren syndrome on a biopsy of the salivary gland is called lymphocytic sialadenitis, which means lymphocytic infiltration of the salivary glands. And this is a picture of that on the screen here. You can see that lymphocytes have invaded this person's salivary gland, and that's the characteristic finding of Sjogren syndrome. And you should know this term, lymphocytic sialadenitis, because that's a buzzword for the USMLE. Many patients have primary Sjogren syndrome where they just have Sjogren syndrome by itself. However, it also occurs secondary to other autoimmune conditions. For example, many patients with rheumatoid arthritis and lupus will have their condition complicated by the development of Sjogren syndrome on top of their other autoimmune disorder. And then a disorder where it's particularly high yield to know about Sjogren syndrome is primary biliary cirrhosis. This is a disorder where there's autoimmune destruction of the bile ducts, and almost half of these patients, or sometimes more than half, can develop Sjogren syndrome symptoms. There are 4 antibody tests that are relevant to the diagnosis of Sjogren syndrome. The first one is the anti-nuclear antibody test, or the ANA. You may know that this test is abnormal in lupus and many other autoimmune disorders, so when it's abnormal, it's not specific for Sjogren syndrome. However, a negative result makes Sjogren syndrome less likely. The second antibody test is the rheumatoid factor. This is positive in rheumatoid arthritis, but it is also elevated in patients who have Sjogren syndrome. Interestingly, it can be elevated in patients who have primary Sjogren syndrome as well as in those who have Sjogren syndrome secondary to rheumatoid arthritis. And then the final 2 antibodies are the SS antibodies. The first one is anti-SSA, or the Rho antibody, and the second one is anti-SSB, or the La antibody. Both of these are abnormal in patients who have Sjogren syndrome, and in fact the SS stands for Sjogren syndrome. And as we will see later, elevated levels of these antibodies in Sjogren syndrome or otherwise are associated with the development of neonatal lupus. To make the diagnosis of Sjogren syndrome, you can also measure tear and saliva production. The way tear production is measured is through something called the Schirmer test. This tests reflex tear production. Filter paper is placed near the lower eyelid of the patient, as I've shown in this drawing on the screen, and then the patient closes their eyes, and you measure the amount of wetting on the filter paper that occurs over 5 minutes. You can also test the function of the salivary glands clinically. The first way to do this is with salivary gland scintigraphy. This is a nuclear medicine test where you administer a radio tracer and you look at the uptake of that radio tracer by the salivary glands. If the salivary glands have been destroyed by an autoimmune process, there will be a low uptake of the radio tracer, and this is what you see in patients who have Sjogren syndrome. The other way to test the salivary glands is to literally measure the amount of spit that the patient can produce. This is called sialometry. In this case, you ask the patient to collect all the saliva they can produce over 15 minutes, and then you weigh the sample. You can make the diagnosis of Sjogren syndrome if you have any 4 of the 6 criteria I've listed on the screen here present in a patient. So first of all, you need typical Sjogren syndrome symptoms in the eyes and in the mouth. Also, you need some objective evidence of those signs that they're coming from decreased tear and saliva production. So objective evidence of the ocular signs include the Schirmer test, like I showed you before, and objective evidence of the oral signs includes salivary testing, like I showed you before. And then finally, another criteria is a biopsy result showing lymphocytic sialadenitis, as I discussed before. And then the last criteria are the SS antibody tests. Importantly, the 4 criteria you use to make the diagnosis must include either histopathology or the autoantibodies. You can't have just symptoms and signs. And the reason for this is because, as I told you before, some elderly patients will develop sicca symptoms, but they are not due to Sjogren syndrome. Those patients won't have abnormal biopsy results or abnormal antibody tests. And then there are also a number of systemic diseases like amyloidosis that can cause these types of signs and symptoms, but those patients won't have the abnormal biopsy of Sjogren's or the antibody test. So you can't have just signs and symptoms. You also need some of this objective data that supports the diagnosis of Sjogren's disease. One of the most important things for Sjogren syndrome patients to do in order to take good care of themselves is to have good oral hygiene. They need to brush their teeth regularly and they need to go to the dentist because, as I told you before, without good saliva flow, you get a high risk of cavities and serious periodontal disease. There are artificial salivas that are available. You can also treat these patients with the muscarinic agonist pilocarpine. I talk about this in the neurology modules, but this stimulates muscarinic acetylcholine receptors, and that will increase the flow of fluid from the salivary glands and the lacrimal ducts. And then finally, sometimes steroids are used for the extraglandular manifestations of the disease, although usually not for the eye and mouth problems. One of the serious complications of the chronic inflammation of glandular tissue that occurs in Sjogren's disease is B-cell lymphoma. There's an increased risk among Sjogren's patients. About 5 to 10% of all patients eventually develop a lymphoma. And the classic way for this to present that you should know for your boards is as persistent unilateral swelling in a gland. And this may mimic past swelling, so the patient may think they're just having a flare of their Sjogren syndrome with a swollen gland in their mouth, but in fact it persists and is much bigger than in the past. That swollen gland may in fact be a B-cell lymphoma. Like all autoimmune diseases, Sjogren syndrome is more common among women, and if women with Sjogren syndrome get pregnant, there is a risk that their baby will develop a condition called neonatal lupus. Neonatal lupus occurs when maternal antibodies cross the placenta and affect the fetus, and it occurs in about 1 to 2% of babies born to mothers who have an autoimmune condition. One of the autoimmune conditions that leads to neonatal lupus is systemic lupus erythematosus. This is where the disease gets its name from. However, mothers who have Sjogren's can also have babies with neonatal lupus. And it turns out that the antibodies that place the fetus at greatest risk for neonatal lupus are the SSA and SSB antibodies. These antibodies can be abnormal in Sjogren's disease, as we have discussed, but they can also be abnormal in women who have lupus. And if women have lupus and these 2 antibody levels are elevated, then their baby is at risk for developing neonatal lupus. The symptoms of neonatal lupus occur at birth or in the first few weeks of life. The first symptom, and usually what's most noticeable, is a rash. This is not the typical rash that you may know from adult lupus. This is a different type of rash. There are multiple red circular lesions that occur on the face and on the scalp. This usually resolves in a few weeks. The thing that is the greatest danger to the baby is congenital complete heart block. This is an EKG of complete heart block on the screen here. And babies born with congenital complete heart block from neonatal lupus will have a very slow heart rate, usually in the 50s. This often does not respond to steroids, and unfortunately the babies often go on to need to have a pacemaker implanted, which they will have for the rest of their life. And that concludes our module on Sjogren syndrome.